Hi, I'm Eric Hartman with the Choroideremia Research Foundation, and I am here with Dr. Franz Cremers from the Netherlands. And for those of you that do not know, Dr. Cremers discovered our CHM gene mutation in 1990 and was certainly the cornerstone of helping build our research. Dr. Cremers, you were given an achievement award by Retina International last night.
Yes.
And it was I know you were pleased with the honor, but we were certainly pleased for you. Yeah. And I was wondering, there's been a lot of discussion about the future of CHM research, of whether it's site replacement therapy, gene therapies. But you had an interesting point in your presentation today about Stargardts, about siblings that were not phenotypically showing symptoms of the disease but had the mutation.
Yes.
And we have a set of brothers that Ian McDonald is going to be doing a full genome sequencing in, where one of the brothers, who is 45,
Yes.
has no symptoms. And when you look in his eyes, his retina looks beautiful.
Okay.
But the 35-year-old is walking with a cane and very, very blind.
Okay.
And one of the things that I'm wondering what you think you may have learned with the patients like that in Stargardts. Are there indications that we may be able to find some future therapy or treatment by studying these patients that are not showing any phenotypical manifestations?
Interesting question, I must say. So I think that you have siblings, male siblings that have both the causal mutation. One is affected, one is not affected. It's quite rare, I think, for choroideremia. You would probably agree with me that it's quite rare. It is a little bit less rare in Stargardt disease, but nevertheless, it can lead to the identification of some modifiers. And of course, if you find modifiers, you may understand more about the disease, and thereby maybe you can find some new clues for treatment. But it's a big but, as you know, we would not be able to predict whether these modifiers, whether they would be strong or weak, and how many there are. And if there are very many, they may be difficult to find. If there's just one or a few, they may be found, and that also may give us new insights for treatment.
Okay.
Nevertheless, I think that the general treatment aspects of choroideremia are still about replacing the defective gene by a new copy.
Sure.
And thereby having, a real, let's say, addition of the gene product in the end for long term. So I think both for Stargardt disease and for choroideremia, that is still the major way forward.
Okay.
Nevertheless, the scientific interest to find these modifiers is high, and also may give us some modifiers that act not only on these conditions, gene defects, but also on other IRD gene conditions. So in that sense, I think scientifically there's lots to be learned.
You mentioned the rarity of the brothers where one is affected and one isn't. There's been some discussion within our foundation that we don't know how rare it is, because for many, many years, if a family was examined and one of the children was showing signs of choroideremia, then he was tested.
Right.
If he wasn't, if there was another sibling that wasn't, he wasn't tested.
Right.
So it may be rare, but it may not be as rare as we think, because siblings haven't been tested.
Right.
And do you think for a future standard of care that we should have all the siblings within a family genetically tested?
I would fully agree with that statement. I think we should test all siblings. Nevertheless, then in every family there are ethical considerations still, because you may not want to test a person that is completely normal. And that discussion we also had in the Stargardt studies. So coincidentally, we found these non-affected individuals that carry two variants. But I think as a standard care, I think it would be good to have the full family analyzed and just explain very well up front to all people in the family why we do this, and that we learn from this scientifically, but also for the patient community. So I think I would be a strong advocate to do this. Yes.
Thank you. And one final question has to do with patient data.
Yes.
We have had quite a number of patients that have been in very large natural history studies and we also have academic areas or large institutions that have done a lot of study of choroideremia patients. And we realized that natural history data has great value if we can consolidate it. And in the United States, there's an organization called the Critical Path Institute that is working also with the EU, where they are literally going to store all the data will be in the Netherlands, and it will be GDPR compliant. And I was wondering what your thoughts are on trying to encourage these, both the pharmaceuticals and the institutions that have these natural history databases to help get depersonalized data. We don't want personal identifiers, but we want the general data there, so that I think for future research we may be able to build what may be even an AI-driven natural history model that would be acceptable to the FDA, because in fact the FDA is helping fund some of this research.
Yeah, I think that is very important. So I would also advocate this. I think it's important for both the clinical data in databases to be more explored than it is now. And similarly, and that's also one of my activities at the moment, is to try to get all the variants of all the genes of all the cases linked to those in an anonymous way in databases. We call those the LOVD databases that are in Leiden, let's say, sort of stored. But I think it's similar, right? We want to have access to all the published and even unpublished data that also come via diagnostic centers in this sense. Right. So I would also be a strong advocate that this is getting more attention, that we can collect all the data together to get more data of this in the end as a sort of meta-analysis.
And one final question. Choroideremia has for many, many years, except for very learned men like you, been diagnosed initially as RP. And there are many, many patients that are living with that. And we want to make sure all patients get the hope that's there, whether it's for different RP research or not. I was wondering what your thoughts are in trying to go back to people that have an RP diagnosis to go ahead and get tested so that they can better understand what their genetic mutation might be.
If I understand your question correctly, then also to find some of the choroideremia mutations that are in RP cases. And in fact, it worked both ways. Some choroideremia phenotypes, in fact, have RP, X-linked RP. So I think all of these patients should be tested by gene panels, at the least, where all the genes are in there. We are doing this at the moment. We have panels of 110 genes that capture all the rod cone phenotypes. And I think there should be a mechanism that all of these cases are phenotyped sooner than later. So I would agree. Yeah.
Well, it's been a real honor to see you again.
Yes.
And thank